Hello, I am Jan Dalberg. Welcome to this presentation. I am Chief Physician in the Pulmonology at Medical Department here in Kolding Hospital. And it's important for me to tell you I am a clinical doctor, I am not a researcher. So this presentation I give you today is not a professional researcher report. It is from the clinical doctor standing beside the patient in the COVID-19 crisis. This Kolding hospital was chosen as one of three hospitals in our region here in South Denmark. It is around 1.2 million people, and we should take care of 300,000, around 300,000. Next picture. The pandemic was a reality for me. It was in the middle of February, end of February. I was sitting in the North Europe reading reports from the world, and I could see reports from China. I was afraid when I read the reports because I could see there was a very big pulmonary problem. Next one. We tried to estimate what will be the problem here in our region. If we had around 300,000 people, maybe 20% will be infected with SARS-CoV-2. If we estimated 10% of them will be admitted to the hospital, it will be 6,000 people. And if we estimated around 10% to be admitted to the intensive care unit, it would be 600. That would not be possible. Even in this modern hospital here, we have not the capacity. So we thought we had to prepare us to be ready. Next one. We started to train the nurses, the doctors, the secretary, the laboratory. Everyone was training, even before we got the first patient. Next. Then I saw this picture from Bergamo in Italy. And then we talked together here, the doctors and the nurses, and we changed a little bit, and we prepared 100 beds to take care of these patients. Next. This is an X-ray from a 27-year-old man with COVID. And if you look at this picture, you can see the lungs are not black. It's not full with air. It is filled with inflammation. You can see especially the right side is filled with inflammation. And we knew when you have this very serious inflammation, you will get problem with the diffusion in the lungs. And then we thought, okay, if you have problem with the diffusion, then we all usually needs help from the intensive care unit. And in the intensive care unit, we have maximal 30 beds, normally 15. I also can see two problems in this picture. The one is mechanical problems, the other one is diffusion problem. So it will need that we will choose a good treatment with medication and a good treatment with mechanical ventilation. Next. Therefore, our first choice was high flow treatment, as we knew, and we have a good experience with this modulation. It's a treatment which is very good when you have hypoxemia and if you have diffusion problem in the lungs and if you have infection. So we started to treat the patient with this modulation. Next. The next one, or the second choice was non-invasive ventilation. But the problem with non-invasive ventilation is that the medical department, we cannot supply with high oxygen treatment together with non-invasive ventilation. Next. But our equipment, there we have a possibility to give continuous CPAP. And we found out it was extremely effective in these patients, COVID-19 patients. If we had a patient with high flow treatment with maximal 60 liters per minute and 60% oxygen, if we changed to continuous CPAP, they reached in a few seconds, minutes, up to 90% saturation. So it was also a very good treatment for these patients. Next. But early we identified three major problems, and it was four problems more maybe. And it was the serious lung inflammation. It's resulted in major hypoxemia, but we almost never identified hypercapnia. Second, the oxygen saturation was very unstable in the COVID patient. And progression in the inflammation caused more and more unstable oxygenation and the more unstable patients. The oxygenation and the saturation in the blood could vary from 70 up to 90 in a few hours or even minutes. And if first the patient was unstable and it continued, then we knew, okay, then we have moved the patient to the intensive care unit. And the third, every single COVID-19 patient is isolated. Therefore, if the patient was unstable, the nurses had to enter the isolation room around 50 times every 24 hours, about 2 times every hour. It means a high risk for the nurses to be infected and to be sick. We had lack of nurses before, and then will we have any more lack of nurses. It also means a high use of isolation equipment, glasses, gloves, masks, and so on. And always when I work, I have to think about cost benefit and what is the price for this single equipment. We found out it was very high. Next. Here you can see on your right side in the slide a specialist in infection diseases teaching a young doctor on the left side, and that is very, very important in this pandemic. And then we tried to calculate what is the price for a complete barrier protection outfit, and it was around 10,000 euro per month per patient. The price for one patient at intensive care unit is around 5,000 euro per day, but it will give 160,000 euro per month. So if we could do something good to protect the nurses, protect the doctor, to a good treatment for the patient, and to try to move so few as possible to the intensive care unit, then maybe we could manage all. Next. Then we found out to try the O2matic. We have heard about it, of course. Somebody calls it oxygen robot. We have used, we look forward to have it in our hospital, and we had to buy some. It was easy. You can see the prices only if you can go down to use to change the isolation equipment every 1 times every 3 hours instead of 2 times every hour. We had the money to buy this equipment. And we've got this equipment in our department around, I think it was around November 2020. And that we did was to place the O2matic between the patient and the high flow, between the patient and the non-invasive ventilation, between the patient and the CPAP equipment. And then it was the O2matic that titrated the oxygen to the patient through high flow or non-invasive ventilation or continuous CPAP. And you can see on the left side, this is a COPD patient. We used it for some of them. On the left side, you can see it is titrated to 0.2 liter per minute. And then we can take these patients out of, for example, non-invasive ventilation. Next. As I told you in the beginning, I am not a researcher and not data from a researcher. And my problem was also to have the nurses to protect them against COVID. And here you can see in the beginning of September, October, the infection arises again. And this is infected nurses with SARS-CoV-2. And then you can see we got the equipment in November, but it took 1 month, around 6 weeks to train all the nurses. So in December, January, we were ready with this O2matic oxygen titration. And then the cure fall again. The nurses seems not to be so infected as before. Of course, we started also vaccination, for example, in the middle of January, but I think the major effect is because of a very good titration of oxygen. Next slide. This is another slide showing a fraction of patients we had to move to intensive care unit. I work very close together with intensive care unit. I am together with the doctors every day speaking about problems. The peak you can see in August is because we had only 4 patients in our hospital and 2 of them was in intensive care unit. Therefore, it is 50%. But in the following months, the infection are going up. And you can see again, we come to January, where the nurses are trained with the equipment to titrate the oxygen titration with O2matic, and then the fraction we had to move to intensive care unit are falling to the summertime again. Next. So, what was our experience and results using O2matic? It was for me very important to stabilize the patient, and that could O2matic. I could see if the patient was unstable and if the inflammation rise, the patient will move to intensive care unit 24 hours later. Now we had a protection of the patient is more stable, the patient can sleep, and on this equipment, O2matic, we choose the saturation interval between 92 and 96, and therefore the patient can be totally stable. Of course, if the inflammation go on, some of them have to go to the intensive care unit. After minutes, up to half an hour, the patient normally stabilize separation interval to choose. It means a stable patient. So instead of entering the isolation room 50 times every 24 hours, it is reduced to typically around 10. The need to move the patient to intensive care is reduced. The risk to exceed the capacity in our ward and intensive care unit decreases. And at last, O2matic also stabilized the COPD patients treated with non-invasive ventilation. We experienced that the time we normally spent on transmitting the patient from non-invasive ventilation to nasal oxygen, for example, was only half, approximately 2 days instead of 4 days, 5 days. Next. This was my words. Thank you. Enjoy the nice autumn if you have an autumn. Thank you.
For more information, visit O2matic.com.